Welcome, everyone, and thank you for participating in this important discussion today. I'm Amy Goldstein, and I'm the director of the Alliance to Advance Comprehensive Integrative Pain Management. And I'm moderating today with Cindy Steinberg, the Director of Policy and Advocacy for the U.S. Pain Foundation, and she'll be speaking to you in just a moment. We're really excited to spend a few minutes with you and kick off today with some context and background to help us explore equitable, scalable, value-based pain care. We are excited for you to hear from our esteemed panelists today. They'll be talking to you shortly. So ACIPM is focused on connecting the dots to advance equitable, whole person, multimodal pain care. And as a multi-stakeholder collaborative, we bring together different perspectives who are all interested in sharing the same goal, but may go about how they achieve this goal in different ways. So that's why it's very important for us to simply connect the dots. We do this with a few things in mind. We keep people with pain at the center of the pain care that we're advocating for. Now, this is really something we stand behind in all that we do. We harmonize input into accelerated action. So this is why we bring together payers, providers, patients, policymakers, because so many different groups are working on how to address pain care right now, but many of them aren't connecting. And because of that, we are not moving as quickly as we can. So we want to advance quality pain care now. And also, we're focused on where the rubber meets the road. Essentially, this is talking about scaling value-based care. This is really where everyone wants to be, yet it's quite complex. So no one can do it alone, and collaboration is key. Now I'm going to let Cindy talk about the U.S. Pain Foundation.
Sure. So thank you, Amy, and we're glad to partner with ACIPM for this webinar. The U.S. Pain Foundation is a nonprofit patient organization with a mission to empower, educate, connect, and advocate for individuals living with chronic pain, as well as their care partners and clinicians. Next slide. Next slide. Thanks, Amy. We accomplish our mission through a broad range of programs, including federal and state policy and advocacy, the Invisible Project, which is an awareness program that features individuals living with pain, approximately 60 different support groups that have trained leaders around the country, a pediatric program for children and teens with pain and their families, and many others. Next slide, please. Each year, we reevaluate and select our top advocacy priorities. And for this year, and the past couple of years, actually, our top two priorities have been to promote a movement toward individualized, integrated, multidisciplinary pain care as best practice, and to work to improve access to a full range of therapies for chronic pain, including integrative and complementary modalities, restorative therapies, behavioral approaches, interventional procedures, including innovative medical devices and novel therapeutics.
Thanks, Cindy. So what are some pain realities? I think many of us already know this, but chronic pain is the #1 cause of disability globally. 1 in 6 Americans lives in pain every single day, yet we actually know how to treat this pain. Multimodal pain care is the gold standard, but it's just not accessible for so many people, especially those who are underserved. So what do we mean by multimodal care? This is a visual that we call the Comprehensive Integrative Pain Management Toolbox. And if you can't see this very well on your screen, we've sent you a link in the chat where you can pull up this visual and make it as large as you'd like. This was created to really help people understand and see, what this kind of care can look like. So you can see that we have an individual with pain at the center of this care. And then there are numerous biopsychosocial factors that have great impact on any individual's ability to get the care that they need. You can see some of those factors on the left-hand side. And then in the middle circle, you'll see some areas. You'll see complementary and integrative health, behavioral health approaches, restorative therapies, interventional approaches, medications, and digital technologies, with some examples of each of those areas. Now, we know everyone doesn't need all of these things. And also, most people wouldn't necessarily benefit from all of these things, but it does need a team approach to make sure that there is shared decision-making and collaboration for each individual to get the care they need. So then why isn't this care easily accessible for so many? Well, we know there are numerous challenges that many of us deal with probably every day. So some of those challenges are misperceptions and stigma. And this happens with people with pain, with clinicians who care for them, dealing with stigma from all areas, from friends, family, coworkers, health system, etc. There's a lack of public awareness as well as a lack of the provider education and training to really understand and have a solid insight on the complexities of care and the range of the toolbox. We need to do better, and communication and education is a key to this. There's business case data disagreements, and payers and providers can often disagree about what models of care are most scalable, most sustainable. And so that's a topic that obviously we're going to be talking about today and getting into some of those issues. Workforce supply and demand. In addition to just an overall provider shortage that continues to worsen, there's also an extreme shortage for an array of licensed and certified providers that are able to care for people in BIPOC communities. Misaligned financial incentives. So achieving value-based care requires innovation to adjust some of the current payment structures that we all live in now. Fee-for-service can make access to multimodal care quite difficult, but bundled payments also may be hard to sustain. So it's really important that we focus on provider and payer partnerships, non-traditional partnerships, to increase access to this care. And lastly, integration and cultural incompatibilities. Now, this is complex and important for people to understand. Efforts to minimize opioid use while increasing access to effective non-pharmacologic therapies is not simple. And there's really a lot of differences in how these providers come to the table. They have been trained differently. There's ways that they communicate about patients differently. The gold standard for a person is to have a collaborative care plan, and that's really hard to achieve when providers don't work in the same health system or use the same electronic health record system. So today we're just going to touch on CMS as it relates to value-based care in this topic. So just some quick notes. CMS is the single largest payer for healthcare in the US, and that means nearly 90 million Americans rely on its healthcare benefits. The national health expenditure has been growing and accounts for about a fifth of the gross domestic product. CMS wants to change the way healthcare providers are paid, and they want to recognize and reward care that is coordinated, encourages good communication, and eliminates redundancy or care that isn't effective. So to that end, the CMS Innovation Center, Objective 1, is looking to have the majority of beneficiaries in value-based care relationships by 2030. That's huge, and we're going to be talking about some of these things today. And one last example before I turn it over to Cindy to say more, an example with CMS adding acupuncture and how that's been challenging in implementation. So in January of 2020, CMS announced it would cover up to 12 acupuncture visits for chronic low back pain. And this has presented us with some really exciting opportunities and some numerous challenges. So on the challenge front, utilization has been low for this. It's driving down payment rates. Licensed acupuncturists have mainly private paying patients from affluent zip codes that we see in a lot of the data. Low reimbursement and lots of paperwork aren't incentivizing the licensed acupuncturist participation in insurance. And in the Social Security Act, which defines qualified providers to be paid under Medicare, licensed acupuncturists are not on that list. They are, however, have the most extensive training to provide this care. Again, that doesn't mean others can't provide it, but we're talking about the most amount of hours in training in terms of that care. Now I'm going to turn it over to Cindy to say a bit more about the billing codes that we had talked about. Cindy?
Yeah, so sort of a very big development in the CMS and Medicare world was the introduction of these Medicare chronic pain billing codes. And Congress had directed CMS to work with the HHS Pain Management Best Practices Task Force to improve pain management in the Support Act. And many recommendations in the Pain Management Task Force report were directed at CMS to encourage and reimburse for coordinated comprehensive pain management. And so CMS went on in July of 2022 to propose specialized chronic pain management billing codes, and then finalize them in the November 22 physician fee schedule final rule, and said that starting January the 1st of this year, 2023, Medicare is going to create these two specialized billing codes that are exclusively for chronic pain management. Next slide. The codes require comprehensive pain management to include, and Medicare lists, diagnosis, assessment and monitoring, use of a validated pain rating tool, the development, revision, and maintenance of an individualized care plan, medication management, pain and health literacy counseling, which is a great way of getting skills and training and education into a chronic pain program, crisis care, and coordination of physician, nurse practitioner, PA, who are the people that are allowed to use the billing codes, with other therapists, including behavioral health, physical therapy, occupational therapy, complementary and integrative approaches, and others. And so it's great that CMS acknowledged the importance of care coordination and will pay the primary practitioner to coordinate with the other practitioners. Unfortunately, they're not paying for the other practitioners, but that's another story. Next slide, please. So the intent of the new codes really was to improve pain care by paying physicians to spend more time with patients on a monthly basis. And these codes are allowed to be charged and are expected to be charged monthly, at least initially when you're working to create a treatment plan, requiring best practices, recommended best practices in comprehensive care management. So those steps that they had included were all steps that were talked about in the Pain Management Task Force report. Emphasizing an individualized treatment plan, integrating a number of treatment modalities. We're glad to see that CMS included, revision of the plan and paying for revising the plan, because of course it's an ongoing thing that you need to do. And then paying the lead healthcare practitioner to coordinate care. Next slide. So while the intent was good, just like the intent for the acupuncture decision, implementation so far has not been so good. So we've asked some stakeholders about the codes and have found that primary care and pain specialists are generally not aware of the codes. They're not talking about their use. And CMS has unfortunately done little to really publicize and educate on the use of these codes. A coding billing expert we spoke to said, we have a nurse practitioner who treats a lot of chronic female pelvic pain, and we asked about using these codes. My research shows it would actually hurt financially to use in many situations. For example, physical therapy has an office visit every month that includes management of this patient's chronic pelvic pain. Assuming the requirements of documentation are there, I can bill G3002, which is the code for chronic pain management, or an evaluation and management code 99214. I suppose there are some circumstances these new codes would be helpful, but not in mine. So basically implying that it's not financially in their best interest to use those codes. And then a physician doing integrative pain care said, I do not have the billing, coding, or regulatory compliance background to be able to advocate for these codes. I'm being told they're less reimbursement than what we're already using. Next slide. And so looking at the comparison for these codes, you can see there's a financial disincentive for using the G3002 code, the base code, because it has a lower reimbursement rate than the existing evaluation and management codes. There is the ability to add on an additional 15 minutes for a payment of $30. But if you think about a practice, the physician could be on to the next patient by then and get another $115 instead of the $30 that they would get for adding time on to this patient. Amy, I'm going to turn it back over to you.
Great. Thanks, Cindy. Yeah, that is a lot for us to think about. And now we are going to hear from some of our panelists. So we want to start with Dr. Church and just kind of kick off the conversation, with you and get some of your insights as a primary care physician working in a rural practice. And if you could just tell us a little bit about your background and also, what do you think is necessary to change patterns in primary care?
Oh, that's a big topic. I'm going to give you all the answers here. Yeah, I am a family physician with a broad spectrum practice. A lot of my background, though, in advocacy nationally is regarding billing and payment, and I serve all of you on the CPT editorial panel as well, where the AMA rules are made for this stuff too. When we can talk a little bit more about that later. Let me go to the next slide. One more. So what we're really talking about, well, there's a lot of themes here. One is how do we change what we're doing? But the most important is how do we take better care of our patients, and our system is struggling with payments as it is. And many of you may not be familiar with the quintuple aim. It started way back with the triple aim, but unfortunately focusing on those three noble topics of patient outcomes and patient experiences and lower costs, what happened was the clinicians got left out of that equation, and that didn't work. And so now we added in the clinicians and their teams, which made sense in the first place. And now we have this quintuple aim that includes health equity. Now, the goal of this is, emphasizes the importance of enhancing the patient experience, fostering trust and communication and engagement between the patients and our providers. This is a perfect kind of meshing of all these topics, because we all want these goals, and it makes sense. And it shouldn't matter what zip code you're in to have access to good care and the right care. And it's a shared goal for us all to be able to do this in a more efficient manner, but it shouldn't make you have to be as a provider to have to lay off staff because you can't pay for the services that you're providing. And there's not enough of me in family medicine. There's not enough pain management specialists, and so how do we navigate that when it looks like there's not enough of us? So that means we've got to come up with a better way of doing things. Let's go to the next slide. All right, so we've got some habits of, well, I mean, you can put it in quotes, on the lower value that's in the eye of the beholder, but we certainly were trained to do things a certain way, and certain things certainly cost more. It costs more to go to the, you can go back to the, you can it's expensive to go to do this stuff in the emergency department, for example. But that's how we were all trained. The whole system was trained with a certain set of tools. And then doing things in a different way, it's competitive with those things that we already do. So now we're trying to do something else that is untested to try to change our habits. And these new tools, like, you can Google the new codes, but nobody knows how to use them. Like, this is new, and I'm thankful for these the next speakers coming up that are going to share some innovative strategies that are outside the box. But this is as basic as, how do you even document with those new codes? There is not one electronic record that is designed for a 30-minute encounter that might take place over 1 month. And then your teams, like, do we have social workers and counselors and all the other tools in the quiver ready to do this? And we know that a full spectrum approach is the best way, but we're already fragmented even without these new codes. And it's already been stated earlier that if you're going to get paid more for doing it the old way, like, at the very minimum approach, you can't do business that way. And of course, to say, hey, come on and join us, we'll do this new innovative model and we'll pay you less, that does not bring on extra people either. So get the next slide, please. So this stuff is slow. We have to unlearn our old habits, and some stuff is very good, so but not great. And so we do what we know, and it is a difficult process, and I've been through lots of changes. I think the most basic one is those of us who used to use paper charts, and we wouldn't want to go back, or many of us wouldn't want to go back, but that was a big change to do things differently. But there are different reasons why people while we change or don't change. Some people just want to do it because it's the better way to do it. Like, you might give your personal cell phone number. Please call me. Don't go to the ER. We can help you. Just because you want to keep those folks out of the emergency department. But not everybody operates on thanks. And then sometimes it doesn't feel like you're working to the top of your license. And so some of these codes compete with that as well. And certainly we have salary issues and kind of paying debts and loans for schooling and all the teams and equipment that are required to provide this care as well. And of course, we also want to do a great job. We want to tackle this challenge of good care. And then that brings us back to the value-based stuff. Like, on an individual practice level, it is hard to understand that, where it fits in the big picture. If you're seeing as many patients as you can see, doing the best you can, like, where does that fit in? Just because it costs the system more, if they happen to go to the ER for something, how does that affect you? And so it's going to require some bigger, broader thinking when we are talking about value-based care, where there is reward for all to help us be motivated way beyond those several codes that have been introduced. Let's go on to the next slide. Actually, so the chronic care management, I was not the original author of those codes, but I was instrumental in some updating of those codes. And I'm just going to briefly mention some parallels with that. I think it's maybe frustrating for those who were so strongly advocating for the G3002 codes to be brought on, but I am not at all surprised. It takes a while just for us to know that those new codes exist. And so that's one lift. But even with the chronic care management codes, CMS has been heavily pushing those, but that is not consistent with the way most of us have been taught to deliver care. So now, years later, it is still slow on the uptake. Well, we know that that's a better way of taking care of folks. But it's not just about the exposure to the codes. Then we've got to change the doctors and the leaders of the teams. And again, there's not enough of us. So what is the motivation for doing that? And then the hospital systems are like, we don't have the infrastructure to do this different. We'll talk a little bit more about that later, but I will say that there are some related codes to the chronic care management codes, which it's called principal care management, that at some point, perhaps these pain codes could be done in that light as well. I think there's some challenges with the G3002 because it doesn't include the rest of your team, and those are physician and QHP codes, but the principal care management codes might fit nicely in there. So we'll talk a little bit later about maybe how this beginning set of codes is maybe a building block to what we do next with the evolution of creating better codes that do it right. So what you're going to hear later is really going to be the starting point for that. This is not the end as you're complaining or frustrated. This is the beginning of doing things better. So I'll pass that on to our next speaker.
Thank you, Dr. Church. That was great. And now we want to hear from Ms. Johnson, who's the Vice President of Practice Advancement at the American Academy of Family Physicians. Thank you for being with us today. Can you also answer the question from your perspective? We talked about how, you and Dr. Church both are connected with AAFP, but of course from different vantage points. And if you could also share a little bit about your background before you share your comments on this. Thanks.
Sure, Amy, thank you for the opportunity to be here. Thank you to Dr. Church for his work, who is an AAFP member and an exemplar for all primary care physicians and other physicians in terms of understanding the payment landscape and applying that in his practice in ways that really best serves patients. So the American Academy of Family Physicians, the work that we do is on behalf of 129,600 family physicians, including students, who are working to deliver high quality and equitable access to primary care. So what we work on within my division at the Academy, which is practice advancement, is really policy, advocacy, education, and member resources related to practice, payment, and career topics for family and primary care physicians. So by way of background, though, I've only been in my role at the Academy for a couple of years. And before that, I come very much from this sort of multi-stakeholder view of the world, having worked with employers who care very much about things like pain management. I was a benefit consultant for the first 20 years of my career, and worked with employers who cared a lot about the productivity and well-being of their workforce and struggled, frankly, with helping their patients find good care for chronic pain and also ensuring they have good coverage for that chronic pain. It was during my time actually as a benefit consultant where I became a big champion for primary care. Took that with me to some work on the payer side where I had the opportunity to work on the development of a medical home payment program in the early 2010s that served as foundation for value-based payment strategies. And really sort of some additional work that I did from a multi-stakeholder perspective in Washington State for a period of time with the Washington Health Alliance, where we actually implemented a low back pain implementation collaborative across health plans, hospitals, employers, and state agencies, just really speaking to sort of the collaborative nature of this work. So every day at the practice advancement team at the Academy, we work to strengthen primary care and equitable access to high value primary care, And we think that payment is not the only important ingredient, but an essential ingredient to get right. And so we are interested in strengthening not just the amount and level of payment, knowing that primary care has been undervalued for many years, but also the form of payment. And so while codes like what we're talking about today in terms of pain management codes are important, need to be adopted and implemented, and we support members in doing that as much as we possibly can. We also advocate really strongly for more flexible value-based payment arrangements that lean less on fee-for-service coding requirements and more on prospective population-based payments that really provide practices with the level of payment in a more flexible form that allows them to invest in the resources and supports that they need to manage their patients. We know that the level of pain, chronic pain in the population is increasing. We know that primary care physicians and their teams play really, really important roles in helping to address this. And we think those kinds of flexible payments that allow practices to implement some of the newer modalities or partner with those who deliver other modalities of care. And I shouldn't say newer, they're well established, but newer from the perspective of the insurance lens and the payment lens in traditional healthcare systems. And it speaks also, I think, to the training limitations that we are trying to sort of undo in many instances in terms of understanding the broad scope of interventions and modalities of care that are available that we'll hear more about. So with that having been said, I will also finish, Amy, by just pointing out that the work that we do is not just focused on equipping members with information and resources that they need to be paid adequately and sufficiently for the work that they do, but also we'd spend a lot of our time with other stakeholders. So purchasers and purchaser coalitions, payers and health plans, and many who are employing family physicians to really make sure that the model of care in place really supports the populations that they're serving. Because at the end of the day, it really does come back to what we hear most from our members is not about payment, but really, how do I take good care of my patients on an everyday basis? And that's what we're here to support.
Well, thank you so much, Karen. And you are speaking my language, of course. I appreciate all of that. And that really segs so nicely into moving on to our next presenters. So other presenters are also doing innovative work, and some that is transdisciplinary. And so what do we mean by transdisciplinary? Because I know that's a term some are very familiar with and others have no idea what we're talking about. And this really, in a simple way, is about bringing together the range of different healthcare providers to work together in real time to create one individualized care plan for each person. And it's kind of dreamy, honestly. And some of us know that the VA Whole Health Initiative has been transformative in moving to transdisciplinary care. And many have been trying to discuss that and model it and think more about it. And so I'm excited to have our next two presenters really talk about this in a couple different models. Now, these questions you see on the screen are just there to let you know, in preparing for this webinar, we asked the rest of the panelists to think about these questions as they prepared their 8 minutes. So you can see they'll talk about their background and role, connect it with the CMS codes that we just talked about, and then talk about the models of care and details about that, including outcomes and scalability. So without further ado, I am going to turn this over to Dr. Toby. And I have had the pleasure of getting to know Dr. Toby in this past year, and excited for you to learn more about what he's doing. So Dr. Toby.
Yeah, thank you so much, Amy, and thanks for the opportunity to present at this webinar. And I will address all of the questions that you just saw on the slides during my talk. I'm going to start with a little background about myself and my role at Savas Health. I serve as the CEO at Savas, and I am a physician scientist originally trained in Germany. After completing my PhD in 2000, I came to the United States and trained at Yale, UCSD, and UCSF. And after my postgraduate training, I joined faculty at UCSD in the Department of Anesthesia, and then later also in the Department of Psychiatry. During my time at UCSD, I completed a master's program in clinical research and served as the director of clinical pain research there. I'm board certified in anesthesia, pain management, and addiction medicine. And after about a decade in academia, I went into private practice. And this is where I developed what I call the unitized transdisciplinary care model, which I'm presenting on today. And I got the opportunity to scale in a payer-provider partnership to currently 8 locations where we are treating our patients with this model in Southern California. And Dr. Williams, you can see here on this slide, will be supporting us in our future efforts to scale this program further. Next slide, please. As to why our model was developed, our model was really developed to address the current crisis in healthcare delivery, and we briefly touched on that previously. It is mainly driven by patients with complex conditions. And we focus on what I like to call the 550 problem, the fact that about 5% of patients count for almost 50% of the total cost. And the exploding healthcare spending is driven by the huge resource demand of complex patients and meeting that in a delivery system that was not really developed to address this efficiently. And pain, as you can see, is a quintessential model to create and test a solution. As you can see here on the right, pain represents one of the largest portions of the healthcare cost. And by its biopsychosocial nature, it demands an integrated and transdisciplinary approach to achieve best clinical outcomes. Next slide, please. To expand on why we developed the problem, because the program, we don't only have a problem with escalating cost, we also have a problem with supply. We are facing several factors: aging physicians, reduced numbers of specialists, and increased demand on all providers because of complexity of patients and all of that fueling burnout. And although med school enrollments are up, all this is resulting in a dramatic shortage of physicians, nurses, and other healthcare providers by 2030. And higher complexity patients cost more than 8-fold the amount of simpler patients. And the current healthcare delivery system does not address that problem. It does not address the need for coordination and complexity involved in complex care delivery. And trying to use the fee-for-service delivery system significantly drives up cost through multiple visits with multiple specialists and often without really improving outcomes. Next slide, please. This is, why we are fortunate to have developed a system over the last 10 years. We started pretty early on this, and that incorporates the 4 pillars of value-based healthcare, and it solves for that problem of complex patients. The reason most integrated models have not been scaled in the past is because of variability in execution. We've managed the variability by making our model technology-enabled. So we can manage variability, but the technology platform also allows us to build in consistency and precision in execution by controlling workflow, the patient journey, and aligning provider behaviors. And the 4 main highlights of the unitized transdisciplinary care summarized here to the right are: it solves the supply-demand mismatch, it solves for the increase in cost, it provides automatically measurable value and outcomes, and lastly, it solves scalability and reproducibility of care delivery. Next slide, please. I'm going to cover a little more detail why our model is scalable. So this unitized transdisciplinary care is a value-based care delivery model that is based on maximizing what we call the face time efficiency of providers and patients. To do so, we've leveraged digital health to match capacity with demand, allow for scalability, and eliminate variability of care. How we achieve this is depicted on the left side of this slide by the efficiency metrics. We address capacity on the vertical axis by our ability to adapt our schedule in real time using technology. It allows us to modify our patient-to-provider ratio based on the patient needs, ranging from single provider to single patients, all the way to groups of patients and teams of providers. And we address the demand on the horizontal axis by expanding the medium of interactions from in-person visits to virtual visits or a combination of the two. Next slide, please. covering a little about the program structure. The program structure was designed to be a patient-centered and provider-centric solution. The system makes it easy for the provider to spend time with the patients by minimizing administrative work, which is mainly done by the software solution. And it helps to drive outcomes, it improves patient satisfaction, and it optimizes costs by managing healthcare utilization. Next slide. Here we see why our system is truly integrated. It allows for a modular combination of healthcare professionals from different disciplines to address the complex pain patients in a transdisciplinary manner. This makes it easy to access for patients and easy for providers to deliver care as a team. On the right, you see the pie chart showing the determinants of health. As you probably already know, the social determinants of health and health behaviors represent the biggest factors of health that we all address in our model. And for this, we use some of the new billing opportunities, and some of them are the chronic care management codes, complex chronic care management codes, behavioral health integration, and also some of the HCPC that we heard about for chronic pain management. Which to bill and when to bill is something that our technology platform automatically tracks and then automatically bills. So it takes all of the complexity away from the practitioners, and they can really focus on delivering patient care. Next slide, please. This picture shows the concept of our transdisciplinary unit. We typically schedule about 8 patients into a unit, allowing us to see a group of patients where we can categorize by presenting problems, stratify by severity and needs, and prioritize treatment based on this, where all these decisions are made at point of care in real time. Prior to starting the treatment, patient data is collected at the day of visit, reviewed by the care team as shown here in the picture, and then the treatment is planned and executed, matching patient needs with provider access. Next slide, please. I want to cover some of our outcomes that we have. We're going to start with looking at the emotional outcomes first. Shown here are the results for pain catastrophizing and depression, because these 2 behavioral health measures are the main drivers of chronicity for pain. And to orient you, I know it's a little busy, pain catastrophizing is shown on the left axis, and depression measured by PHQ-9 is shown on the right axis. As you can see, for both 3 months and 12 months data, we demonstrate highly significant improvements over baseline. And just to point out, we have a very robust N, close to 3,000 patients at 3 months data and about 1,000 patients with 12 months data. Next slide, please. Now we're shifting to physical outcomes, and we see very similar improvements. Subjective pain intensity and interference shown on the left axis, as well as disability measured by oswestry and shown on the right axis, decrease significantly both at 3 months and 12 months time points. In the next slide, we're going to look at the patient experience. When looking at the patient's subjective global impression of change, at baseline, they rated all their previous treatments prior to starting in our UTC program as not having had any real impact by rating it as almost the same. At 3 months in our UTC program, they rate their subjective changes as somewhat better, and we're very happy to see that it improves even further to moderately better at 12 months. On my last slide, I'm going to look at the return on investment or the financial performance. During the first 3 years of our payer-provider collaboration, they collected data on over 3,000 of our patients. It was analyzed by a third party and published in a health affairs article from which I took this graph. And let me walk you through the graph real quick. A line above 0 represents increase in spending. A line below 0 represents cost savings. Our clinics are listed as multi-specialty clinics represented by the rusty red bar. And as you can see, we realized cost savings for the health plan of $225 per member per month on inpatient costs and $150 per member per month for total cost of care. And with these quick highlights of our program, it finishes my discussion. Next and last slide. Thank you.
Thank you, Dr. Toby. That was terrific. And now I'm sure we're collecting more questions because this is all a lot for us to think about and ask. Please hold your questions, and we're going to now introduce Josh Plavin, who is the Associate Medical Director with the Comprehensive Pain Program at the Osher Center for Integrative Health at the University of Vermont Medical Center. And looking forward to you hearing from Josh, who I met a few years back when he was at Blue Cross Blue Shield. He'll tell you more about that, but he has since moved over. And this is another really terrific example of moving to transdisciplinary pain care. So, Josh?
Great. Good afternoon. My name is Josh Plavin. I'm the Associate Medical Director at the Comprehensive Pain Program here at UVM Medical Center. We're also part of the University of Vermont Osher Center for Integrative Health, which is actually a 11-center US and European approach for moving forward integrative and complementary health into the mainstream through research, education, and clinical care. Next slide. And actually, I will take a second to to comment on Amy's comment, which was that I have been with this program for a little over a year. Prior to that, I was actually the Chief Medical Officer of Blue Cross Blue Shield of Vermont, which is a single state nonprofit Blue. And prior to that, had been working here in Vermont for close to 30 years and had done health services research training at Dartmouth prior. And so now I'm working at UVM Medical Center as part of an academic medical center. And 6 years ago, we started to identify high impact chronic pain as a significant driver of costs at the health plan in my previous job. And we have developed an innovative bundle for payment, which was developed in partnership with providers directly. So one of the questions that will come up is, how do you pay for all this? Of course, we do not use the Medicare chronic care management codes yet because we already have this bundle. The bundle was developed. We didn't develop the bundle and then transform the care, and we didn't transform the care and then develop the bundle. We did both at once in partnership, which was an important piece, I think, in this. And so my experience with this clinic really is 6 years old, although my clinical experience is 1 year since I transferred over here as a clinician. So our approach here at the Comprehensive Pain Program is to really understand pain as a universal life experience. This is our mission statement, and to understand it as a particular form of suffering, which may also hold an opportunity for growth, increased wisdom, and wellness. And so we kind of live this every day in a transdisciplinary, integrative, including complementary services for patients over a episode of care. And we'll talk about that. Next slide. So again, a lot of this has to do with changing the paradigm of how patients experience healthcare, from things like what's the matter to what matters to you, from curing to healing. Patients are participants, and in fact, we have patient advocates who are peer support within our program now. So there is a lot of transformation within our own system to better meet the needs of these patients and participants, which we actively seek to move forward. Next slide. So let me tell you just about what we do. So we basically developed the original Blue Cross bundle, which has been in place for about 3 years. And that is, in essence, an episode of care. What it's from a financial perspective, the patients or participants experience a primary care copay for once a month for 4 months, 16 weeks or 4 months duration of the program. We have a combination of both group and individual offerings. The group is really the anchor, and that is no more than 8 or 12 patients. And there are 2 pieces to the group experience here. The first half, if you will, is mental health oriented, led by our psychologists and social workers, and they focus on acceptance and commitment therapy, a form of cognitive behavioral therapy. And the second half is a medical group visit led by clinicians like myself, and usually an integrative practitioner or a complementary practitioner. So one piece is the group once a week for the 4 months, essentially. And then there are individual offerings. And those individual offerings are a large gamut of what you've seen on the previous slides, including hypnotherapy, and I'll kind of do it by sections. So from a mental health perspective, if you will, we have hypnotherapy, EMDR for both trauma and chronic pain, and then pain reprocessing therapy. I realize that it's not right there on the list. So we are doing pain reprocessing therapy, which is a relatively new approach, and have trained up in that as well. We also provide medical consultations for pharmacologic and other interventions on the allopathic side. We do a great deal of nutrition work, both individually and in a group format. Our group room is actually a teaching kitchen. And so we also have, you'll see later on, kitchen conversations in culinary medicine. We do have cooking classes, which are led by an occupational therapist, our nutritionist, and a chef educator, focusing on anti-inflammatory and highly nutritious diets. In addition to the mental health therapies, we have psychologically informed physical therapy, occupational therapy, and our movement therapy is yoga, although soon we will be adding Tai Chi and Qigong as well. We also, from an integrative perspective, include acupuncture, massage, craniosacral, Reiki as part of the bundle, and also health coaching, because navigating this and changing health behaviors is a big portion of what we do here as well. So, and then on the bottom right, we have a couple of our kind of group education programs, including an overview of what EMDR is, for many people are not familiar with that. Our culinary approaches, overview of cannabis and its use in pain, just an educational update on that, sleep program, and of course, we have both group and individual yoga opportunities for patients. Next slide. This is our fee-for-service program for those payer partners who we do not have a bundle with. And I will also mention, which I forgot to mention last slide, is we are about to start a 100-patient pilot with Vermont State Medicaid, covering our services as a bundle and actually in an integrated fashion, so that our PATH program, the last slide, would include both Blue Cross and Medicaid patients in the same group. But at this point in time, for other payers, we have a fee-for-service program, which is very similar. It's a 3-month program. The weekly group is mainly mental health, acceptance and commitment therapy, some education on pain protection system or pain neuroscience, nutritional review, and then our individual visits include all the same individual visits, with the exception of non-covered services like acupuncture, massage, and Reiki at this point. Yoga is provided to patients through a grant, so we were able to kind of add that to the offering for free, if you will, to the payer for those patients. So we have 2 programs. Next slide. Transdisciplinary, we feel, is an important component of the program, and if you will, part of the secret sauce of the outcomes that you'll see later. And I think Dr. Toby mentioned this as well. So, you know, as you can see, a transdisciplinary approach is really a blending of skills and scopes, and working both formally and informally as a team. So the formal structure of that includes an intake review, midpoint review, and actually a final review for the all of the clinical staff meet usually via Zoom for a case review. And we talk about patients and their progress in the program and make suggestions to one another about next steps and barriers that we've identified. Then, in addition to that, we are in the same physical space. So that we have informal encounters throughout the day and can kind of get that hallway consult with our colleagues, whether it be acupuncture, Reiki, or it's our psychiatrist as part of the team. So that happens in both a formal and an informal fashion. Next slide. Outcome measures. So we could not go into an episode of care and a value-based arrangement without studying what we're doing. And so we have a pretty comprehensive evaluation system here, which includes, and this is a program pilot evaluation. It's not quite formal research yet because the duration's not quite long enough, but that is the next step. So we use pre-post survey instruments, health survey instruments, DBPRS, PEG, the Promise 29, which is much more on functional outcomes, brief resilience scale, self-compassion, chronic pain acceptance, and what's called health confidence as measures that we use to evaluate our outcomes. On the financial and utilization side, in this case, with the help of Blue Cross, they did the analysis of the medical, RX, total, and musculoskeletal focused cost of the program, as well as interventional pain, prescriptions for opioids, and ER visits. And so they did that as a 12 months pre, 12 months post intervention before, in this case, 112 patients, actually, excuse me, 120 patients for that financial and utilization evaluation. Next slide. So what do we see? So the PEG, unfortunately, there's some overlapping in the slides, but these are statistically significant changes in PEG across the board for our patients, which is patient self-identified pain assessment, average pain interference, and pain interference, as many of you know. Next slide. The Promise 29 looks at these 7 domains of function, and these are really kind of where the most important outcomes are represented. And as you can see, there are statistically significant changes across the board, even just pre-post, as it were, the 4-month episode. We have not as of yet, but plan to do 6 and 12-month outcomes and perhaps longer term outcomes as we move into more formal research. Next slide. And here comes the costs. So this is Blue Cross derived from their claims, and they found that there was a 17% decreased cost, 12 months post-program, which was sustained and durable. In medical, 23% drop in RX costs. There was a drop in total cost of care of 18%, and then musculoskeletal specific costs of 30%. Next slide. And kind of the most impressive finding that we had, at least with this initial pilot evaluation, was the ER visit. ER visits decreased, approaching 70%, which was made Blue Cross quite interested in sustaining this program, and they are very supportive of our further efforts in expanding this program to multiple sites and even into primary care, which is all in the works. All right, and I think the next slide perhaps is the end. So I just want to, just briefly before I finish up, do want to talk about our future endeavors. So of course we have our Medicaid pilot, which starts in January. So it's the whole year of 2024. And we will be doing a formal evaluation of that as well, along the similar lines that we've seen here. And then we will also at the same time be pursuing more formal research to do a little bit more longer term evaluations of the program, but also the implementation. We also are moving into primary care and are creating an alumni program for our patients in a medical group visit format in our local primary care practices. So thank you very much. And my time seems to be up.
Thank you so much, Josh. And listening to both of you, this is just very inspiring and exciting. I know for many of us who are looking for these kinds of programs and increased access to these kinds of programs. So now I'm going to turn to Chris Nackstedt, and he will tell you about his background in TELUS Wellness. But I just want to say I also met him a few years ago, and he's coming at this from another angle that I think will be really interesting for all of you in terms of developing a narrow network of skilled integrative providers that can be added to existing benefit designs. And he will say it much more eloquently than I just did, but I think this is another great example of kind of private work trying to address some of the gaps that we're talking about today. So turning it over to you, Chris.
Thanks, Amy. We have a new slot in sales. Maybe you can join us because you did a great job there. My background is as CEO and CFO of health systems and also insurance companies. And about 8 years ago, we started a little firm called Value IQ to help organizations, both on the payer side and provider side, with the transition to kind of fee for value. About 3 years ago, we launched TELUS Wellness, and that's going to be the basis for my discussion today. On our team for TELUS Wellness, many of you know Dr. Lance Luria, and he was really instrumental in helping us as we developed our algorithms for TELUS Wellness. And we also brought on a kind of a technology person that had no background in healthcare, but had a significant amount of background in launching technology companies. And so you're going to see kind of the benefit of all of that. So let's move forward to the next slides here, please. Next slide. Next slide. So I think that the first thing that I'm going to, next slide, please, talk a little bit about is, the problem that we saw. And the problem is really an employer problem that we saw in creating access to types of practitioners that could solve issues for their employees. So pain is a big component of cost for employers, and we've seen that over and over in the data today, but it's also a significant issue for their employees, and not only from the day-to-day lifestyle of their employees, but also for recruitment of employees. And so when we think about this, I would say that I have no history in dealing with the CMS codes that we've had here, and we actually had to figure out a way how do we bypass kind of traditional operating systems in order to bring new care modalities to individuals that are receiving their benefits through an employer. And the idea here is we can focus on self-funded employers that have significant opportunity to rapidly kind of deploy new modalities into their benefit plan. And so if we go to the next slide, I'm going to talk a little bit about kind of what our solution is. And so you'll see that we have 5 modalities: acupuncture, nutrition, massage, chiropractic, and naturopathic doctors. And ultimately, what we found, and we did a number of kind of like employee focus groups across what you might call blue collar employees, white collar employees, all sorts of ethnic groups, and age bands as well. And we found that there's 3 kind of barriers for individuals seeking care in these areas. Now, what I would say is in certain markets, some of these are standard in benefit plans, but in other markets, they're not. And so the first was that they're not always part of the benefit plan, or they're not comprehensively part of the benefit plan. The second is that even if they were part of the benefit plan, or they'd heard of some of these things, they didn't know who or what those modalities could treat. And the third is that even if they figured that they could see an acupuncturist or a massage therapist, there's different licensing in different areas of the country, and even within markets. And so you kind of look at what could treat my issue. I think Amy mentioned exactly in her opening many of those exact same challenges, and we've heard those kind of over and over again. Now, what we developed was a digital platform, and I'm going to just show you kind of a couple of photos of it. And if somebody after this wanted a link to a video that kind of describes it that we use for new member onboarding, I'd be happy to send that to Amy, and then she could share it. But our digital platform, essentially what you're able to do is you enter your symptoms, and you're able to kind of determine what type of practitioner you might want to see. And what we did there is we took all of the science that we could find. This was led by Dr. Lance Luria and then another physician on our team. And we sat them down with a researcher and also a what I would call a designer to design all of those algorithms. So if you enter low back pain as an example, and that's your kind of primary concern, there may be a couple of different types of modalities that would pop up for you. And we developed it so that if there's cautionary items, so as an example, you had a recent break of some bone, it might show up as a caution to seeing a chiropractor, or you should advise your chiropractor of that. Maybe the break was in your wrist, but you're having a problem with your back. The next part that we have as part of our, that we had to overcome was really credentialing providers. And I think we've heard over and over again that it's difficult to kind of get to the core training and background of some of these providers, because even on their websites, it's not clear. So we developed our own credentialing committee. We curate a network of like-minded providers, and we make that available to these members. And the third issue that we faced was both on the provider side as well as on the payer side, so the employer side. So many of these employers use third-party administrators. What we found is that third-party administrators from some of the large payers did not want to work with us, so we had to develop our own payment process. In our payment process, we're able to pay our providers within 24 hours, and most are paid within the same day. And so I think Amy mentioned that as well, like around the acupuncture reimbursement. Our acupuncturists know exactly what they're going to get reimbursed, how they're going to get reimbursed, and when they're going to get reimbursed from us. So if we go to the next slide, I'm just going to show you maybe kind of a visual of our platform here. Up on the left, two kind of boxes here, you'll see it's for Susan Jones. Susan can go on our platform, understand exactly what benefits she has for each of the modalities, how many visits she has left. If she doesn't know what those modalities are, she can go down in the Learn section and understand specifically about all 5 of those modalities, but also what those modalities might be able to do for her specific issues. So we curate articles specific to the largest types of symptoms or complaints that are being accessed on our platform. So it might be anxiety, pain, whatever those happen to be, and the modalities that could treat those. If Susan knows specifically what type of practitioner she wants to see, she can actually just go directly into our quick provider search and enter the information and go directly to it. She can bypass the entirety of it. There's no referral required. If she wanted recommendations, she can enter a little bit more information. But if she completes the health profile, that's where the most information comes to Susan. And that's where the example of like a recent break may come into her recommendations with respect to who and the type of practitioner that she might see. So if we go to the next slide, this essentially delivers for both the employer and the employee. The employers get reduced cost and differentiation, and the employees can self-refer to lower cost modalities. And that seems simple, kind of off the top of your head. But what we found is when we did a pilot with this, it really worked. And if I go to the next slide, please. I want to talk a little bit about the program impact that we did with a manufacturing company in the Midwest. And so I think manufacturing company, it was a really good mix of kind of like what I would call manufacturing employees, as well as administrative and sales employees, and kind of like across the spectrum that we saw. In addition to kind of like this program impact that I'm going to talk about for just a second, is that I would say that the anecdotal letters that we received from the employees were really significant. So when you look at this data, what I would say is that my partner, Donna Golden Evans, who's operating as our CEO right now, she would say, and I would say agree, it's not actuarially complete. We don't have a long enough duration. We don't have a long enough number of participants, but we believe it's directionally correct. So this health plan was costing across 6 chronic conditions, just over $5 million a year. So when we looked at members that were part of the health plan in 2021 and had one of 10 primary complaints in 2021, and were still part of the health plan in 2022, those members that saw a practitioner of ours in 2022 had a 29% cost decrease. Well, those that didn't use our practitioner saw a 7% cost increase. Interestingly enough, of those members, it was almost equally split between those that saw our practitioner or did not see one of our practitioners. The other interesting part is that when we risk adjusted those members in 2021 and 2022, the risk adjustment of those members was also within 1%. The biggest area that we saw was a significant reduction in large claims and ER visits. And so think about admissions and ER visits dropped dramatically in that 29% cost decrease. That was a significant contributor. While, you know, clearly the amount that was paid for these practitioners increased, but the overall cost decreased by 29%. I might just share like one anecdotal member letter that we received, and this individual gave me permission to share it. It was somebody that was in a motorcycle accident 5 years ago, complained of chronic pain, said incurred chronic pain every day for the last 5 years. This became a new benefit. Called one of our acupuncturists. She spoke to him at length, said that she thought she knew what it was, but to come in, and it would take, you know, a handful of visits for him to get true relief. After the first visit, this individual indicated that for the first time in 5 years, there was relief. And just like the acupuncturist has stated, that the pain might start to come back, and indeed it did. And after the 5th visit, this person felt like they were pain-free for the first time in 5 years. And these letters were not solicited. These were actively written to us to show appreciation for the program. So I might just go to the next slide here. And I think that, you know, Dr. Toby said this as well. I mean, we're trying to solve also a supply problem. So try to create access by enhancing the benefits for the employees. It is scalable, but it's not without challenges, because in order to curate that specific network, we want to work with like-minded practitioners, and moving from market to market takes time and energy. But we believe that over time it is scalable. The lower cost and better outcomes, I think, is significant. The clinical guidelines, we continue to refine those, and the payment process has really been disruptive. I mean, that has been a game changer for both us and the practitioners. And unfortunately, we are focused on employers who self-fund their benefits, because that's our kind of pathway into this. And so I might just stop there and turn it back to the moderator.
Chris, thank you so much. This is great to see, and it's exciting to see all the progress since we last connected. I am now going to turn it over to the last presenter before we have our mindfulness break, and then go into the rest of Q&A. So plenty of time for questions. And I'm going to introduce Dave Elton. And many of you who have been on any of our webinars before, I'm sure know Dave. He's been an AAC-IPM advisory committee member, as well as been with United Health Group for a very long time, and he is no longer with them, and will explain what he's doing now and how it relates to this topic. So I will now turn it over to you, Dave.
Thanks, Amy. As you mentioned, 26 years at UHG, a lot of the time in capitation and economics and coverage and policy and networks for physical and mental health business units, and then had a chance to do a tour duty with UHG Ventures, the venture capital entity in UHG, and Optum Labs. And as you referenced, you know, through that, did some research that some folks may have seen that pretty clearly demonstrates the value of these integrative therapies, chiro, PT, acu, massage. Now left UHG in August, and I'm having just a fantastic time working with colleagues at Elite Healthcare, where we're scaling a national management services organization and clinically integrated network, supporting, to Chris's earlier point, high value outpatient evidence-based practices and helping them be successful in the delivery system. And, you know, Amy, I have to admit, when you first invited me to participate on the panel, I was a little reluctant because this was just going to be another session talking about how valued these integrative therapies are. It's like, you know, we already know it. Not much more needs to be done on that. But the catch for me, the hook for me, was when I saw scalable in the title, and scalable for me is code for economically viable. So I anchored on that, and I was all in. And the reason is low and unchanging reimbursement for providers of integrative services are causing these practices to be starved out of the system. They're just not sustainable. They're not economically viable at the level of reimbursement that's out there. In my mind, the question to be answered on all this is not whether these services or approaches are valuable. I think the question really is, does our healthcare system value these services? And so for that, why don't we go right into the next slide? Or the next one. Here we go. So I think, every one of these practices has some variation of the title in mind. In this case, should I have become a Great Clip stylist? So to unpack this, what I did was grab 20 years of Medicare fee schedules for all localities, grab the United States annual inflation rate, and looked at some things. And in our 8 minutes, I better turn on my clock so I don't go over here. In our 8 minutes together, we'll just look at PT on the left, chiro on the right. And so for physical therapy, I constructed a sort of a typical visit. Manual therapy, working on soft tissues, 15 minutes, exercise, 15 minutes, and then an evaluation for a new patient with that cost spread over 6 visits, which is a pretty typical episode for PT. And back in 2003, for that visit, a physical therapist was reimbursed $66 and change. Today, 20 years later, physical therapist is reimbursed $58. So 20 years later, their reimbursement per visit has gone down. And on an inflation adjusted basis, starting in 23, that should be 110 a visit. So declining reimbursement, actually less than the cost to deliver a visit, and half of what an inflation adjusted level of reimbursement would be. That doesn't make a lot of sense, as we'll see. Chiropractic gets a little bit more complex in that in Medicare, chiros are only reimbursed for spinal manipulation. So in this illustration, we're looking at 98940, which is adjusting 1 to 2 spinal regions. Back in 2003, a chiro is reimbursed 25 and change. Today it's 28 and change. Inflation adjusted basis, that would be 42. But if a chiro were reimbursed for exercise, and if a chiro were reimbursed for an evaluation, which we'll unpack that in a minute, they would be reimbursed 71 today, and on inflation adjusted basis, 114. Should be 114, chiros are reimbursed 28. And if we just go off on a sidebar for a minute on evaluation and using the hair clip analogy or haircut analogy of Great Clips. So chiros in Medicare are being asked to treat patients without an evaluation. And that's like going in to get a haircut and putting blindfolds on the stylist and say, have at it. You're probably not going to end up with a great haircut. So that it just doesn't make sense. And then to the haircut, last week went into Great Clips, got tuned up for today. Here's my receipt, $30. I timed the time in the chair, which was 10 minutes and 39 seconds. So 10 minutes, 39 seconds at Great Clips, paying 30. 15 to 20 minutes with a chiropractor in clinic, chiro's getting paid $28. This just doesn't make any sense. Valuable services not being valued in the system. So down below, the intent here in the sort of the tan box is not intending to single out CMS. They've got the fee schedules in the public domain, so they were accessible. Medicaid reimbursement is generally less than this. Commercial reimbursement, maybe it's a little bit higher, but it's unchanged for 20 years. It's about the cost to deliver a visit. And copays and deductibles are rising to the point that in some cases, chiros and PTs are making change on a patient's copay because the copay is higher than their reimbursement. None of this makes sense. And by the way, Great Clips is fantastic, so I'm not trying to hang them out in this, but what this means practically, and WebPT, which is an EMR for PTs, does really a terrific job on an annual state of rehab report, citations to the right. 2022, 22,000 PTs left practice, 12,000 were added to the workforce for a net loss of 10,000 physical therapists. That's an access problem. 9 out of 10 graduates have more than 150K in debt when they come out, going into an environment with declining reimbursement that's nowhere near keeping up with inflation. This just doesn't make sense. But what does make sense, in addition to being terrific clinicians, these integrative practitioners are smart, pragmatic, scrappy business people. And so in pursuit of economic viability to maintain their practices and support their families, they're evolving to cash practices, going outside the insurance industry where people pay cash out of pocket. And what's the target market for that? It's affluent, primarily white zip codes where there's the disposable income to support cash practices. And that only amplifies the disparities in management of pain that, my research and others have pointed out. So again, valuable services clinically, creating tremendous value for patients and for the system, and to the earlier examples, creating cost of care benefits to the system. But the system is not valuing these therapies. And this level of reimbursement is not sustainable for these practices. And in my mind, that's the only conversation for these therapies going forward. It's not, do we need more research to prove these therapies are helpful? It's not, do patients value these therapies? It's these therapies have to be reimbursed at a level that's sustainable. So with that long-winded first slide, 3 minutes left, let's go to the next one. So to answer the question, should I become a great clip stylist? Maybe not if I could be paid for an evaluation. So again, Medicare data, 20 years, looking at new patient eval on the left, established patient evaluation on the right. And interestingly, these services are generally keeping up with inflation. New patient evals ahead of inflation, or established patients ahead of inflation, new patient a little behind, but together they're about keeping pace with inflation. Chiros are not, they can provide these services, they're not paid for them, interestingly. Physical therapy evaluations, which use different codes, are flat. And this is a whole other, discussion on why are these services keeping up with inflation and the integrative therapies are not. Topic for a separate day. So next slide, please. I want to read, healthcare, this, the MSO CIN approach to this. So our thesis on improving economic viability of these practices starts with these independent, hands-on, highly personal, in-person integrative practices are essential to a well-functioning system. Josh's clinical experiences both on the Blues and at Vermont point this out in spades. These practices are essential for patients and for our system to work well. And yet these practices are fragmented, they're isolated, they're underserved by technology because the level of reimbursement doesn't allow these practices to invest in modernized technology. And what that results in is reimbursement unchanged for 20 years. It's not sustainable. The per visit reimbursement is about at the cost to deliver a visit. It's awfully hard to be integrative if your technology doesn't integrate. And so the EHR that these practices are on, you might as well be off the grid or invisible because it just does not connect with the EHRs used by the medical system more broadly and pretty hard to integrate. And then, all this unfortunately results in fewer patients benefiting from comprehensive integrative pain management than current guidelines suggest should be happening. And that's particularly amplified, as mentioned, in the underserved communities. Our approach in a REIT, and time won't permit us to get into it, but to improve economic viability, these practices must adopt modern interoperable technology. That's the backbone of the practices, which is the MSO part of our equation. And then the clinically integrated network is a legally permitted organizational design that brings independent practices together to begin to tap into the economies of scale of a large group while preserving the benefits of local independent practices and brands serving local communities. And then the network angle provides geographic distribution to provide, access, including underserved communities. And then, this gives you the infrastructure and ability to participate in value-based contracts, such as Josh described, where when value is created, these practices need to participate in this value. And Mike, I'll just snap the line here because I'm already over by a minute. We've got some models on how we tackle this that, those that are attending can go get the slides to look at. But, the main point here, at least my reason to join the panel is, look, more research, expanded coverage, new codes at low reimbursement, larger networks, none of this stuff matters. It's all well intended, but the root cause at this point is we have to address barriers to economic viability, or these practices just won't be available for patients. And with that, I need a mindfulness break, Amy. So I'll hand it back to you.
Dave, thank you very much. This was really excellent and really thought-provoking. Those last few graphs that you showed were really something. Anyway, we are going to encourage people to write your questions into the Q&A, and we will get to them very shortly. First, we're going to take a brief mindfulness break with Dr. Isabel Roth. Amy and I are really excited to include Dr. Roth in this webinar because she and her colleagues are focusing on issues at the heart of these discussions. She is a co-PI with an NIH HEAL-funded multi-site pragmatic randomized clinical trial called Optum, which stands for Optimizing Pain Treatment in Medical Settings This study is comparing telehealth group mindfulness with usual care for people living with chronic low back pain. And hopefully we'll hear a little bit more about it later if we have time, but let's first take a few minutes to give ourselves a break. So Dr. Roth.
Thank you. I'm so excited to be part of this incredible group. So we'll just take a moment here to let ourselves digest what we've just heard. If you've been sitting this whole time, I invite you to stretch or stand if you'd like. And if you're most comfortable seated, I also invite you to close your eyes if you're comfortable, or take a soft, gentle gaze. And we'll just take a moment here to find an anchor, whether that's having your feet on the floor or tuning into your breath, if that's grounding for you. Taking a moment here to come into the body, slow down, and appreciate. So choosing that anchor that we'll keep coming back to throughout our practice for just a few moments today. And noticing without judgment what is present in this moment. What physical sensations are present in your body? What emotions are present for you right now? What thoughts are going through your mind? Expanding your awareness here, noticing where we are in space and time, noticing the physical environment that you're in, and also our digital connection with all of these incredible people around the country, maybe around the world. Noticing any light, sounds, smells, or movement in your space, the temperature. Noticing where you are in the world. And then coming back to the body, coming back to your anchor. Returning to the here and now. Noticing those sensations, those thoughts, those emotions, without judgment. Brief mindfulness break today, deepening your breath, wiggling your fingers and toes, stretching as you need to. Might even give yourself a brief self-massage. Coming back together for what should be stimulating and exciting conversation with many people who are passionate about the same issues. So blinking your eyes open and returning to the webinar.
Thank you, Dr. Roth. That was great and really gave us a chance to relax and feel better. So we're going to move into our discussion now. And before we take Q&A from the audience, I wanted to ask any of our panelists if you had any comments or questions for any of the other panelists. And if you do, feel free to raise your hand, use the icon, or you put your cameras on. That'd be great.
I might ask a question to Dr. Elton. This is Chris Naxted. Like, one of the things that we found when we were kind of rolling out TELUS Wellness was we had to in order to get the network of practitioners that we wanted, because I think in any industry, I'm an accountant kind of by background and training, there's great accountants, and then there's like maybe those that you don't want to take your taxes to. And so we find that just like in anything else. And those practitioners that were really like-minded with us, in order to encourage them to join us, we had to value them in a different way. And that way was essentially matching their cash pricing in order for payment. Now the value, it's really low dollars relative to the total healthcare spend. So valuing those individuals from a sustainability perspective was important. And I'm curious about kind of your perspective about government payers, and are we going to see those practitioners just kind of never participate with government payers kind of like going forward? And so acupuncture, as Amy mentioned earlier, is a really good example of that.
It's a terrific question, Chris. And, one attribute of these practitioners, chiro, PT, acumassage, yoga, is, man, they care about people. And the last thing they want to do is shut down access to any particular sort of payer type of membership. And this becomes the economic buy-in that these practitioners are in, is they care for people. They want to provide access. And they're doing it to their own demise around taking a $20 reimbursement per visit and having these, government program constraints on our ability for those patients to supplement it with cash. They are really in a bind, and they cannot make a go of it if that's their sole source of income. So then it becomes a mixed exercise where, I'll open up 10% of my appointment to make sure I provide access to those government programs while I'm really paying the bills off my cash patients, because even commercial insurance, largely mediated through the intermediaries that are beating them up with and low fee schedules and all kinds of administrative headaches, that's barely a break-even proposition. The government programs they're losing money on, but they're doing it out of goodwill. And that's why this cash relief valve, where people can actually become viable, is having this mix of patients. And we just REIT, we see this every single day, looking at practices all around the country, and the box and the bind they're being put in through this tough reimbursement. And so, Amy, I apologize for not answering your 7 questions in my 8 minutes, because this topic is really the only topic to talk about with these practitioners, is how do we pay them so that they're viable?
Can I add to Dave there, if
Sure.
okay? spot on, right? So one of the questions actually had to do with are there essentially why is there not chiropractic part of our program? When we built the program, it was for to target therapies that were not otherwise covered. In Vermont, chiropractic and naturopathy are mandated coverage. So they get covered by all insurers. Their reimbursement, however, is not so great, to Dave's point. So that we have not solved yet. However, I will say that the integrative practitioners who work here have work here part-time. So they have private practice and they work here part-time. One of the reasons they work here, Dave, and others, is because they get paid as part of the bundle for the full episode of care, whether the patient kind of shows up or not, if you will, and they basically have a better financial outcome model for themselves there than if they were running this as a private practice. And so many of them, as we expand, are saying, hey, can we work more with you guys? Because the financial model out there is not sustainable. And to your point about the financial reality about having to take cash on the barrel, as it were, that creates health inequity. And they don't want to do that either. They are good people who are trying to do the right thing for patients. So anyway, I think Dave was spot on. That's the bigger issue. We've not completely solved that, but perhaps it's one model.
Thank you,
If I
Josh.
could pile on that just for a sec, Josh. So what you are doing as an administrator of a bundle is responsibly distributing those economics to the providers, creating the value. And where we see distortions happening out in the wild in the system outside your type of programs or bundles are happening, is the sort of the providers of low value care that are on top of the bundle are keeping the bundle and starving further the providers creating value. So, congrats to you for doing it responsibly.
Yeah, that can be certainly a perverse issue, of course.
Thank you. Other questions that people have or comments on the presentations of your fellow presenters? The panel. Sure, Isabel.
So just stepping back to the kind of the title of this talk around value-based care, I'm still a little bit confused, honestly, about how you get value-based payment systems off the ground. So how you create a bundle and why it is so challenging to make this a more widespread model. One person said, change in healthcare is very slow. So I'm sure that's just one piece of it. But I'm curious if folks could just enlighten those of us who are not experts on healthcare finance about how you make these things happen and why it's so challenging.
I guess that's a question for Toby and for Josh.
Yeah, I'm happy to start with that. Thank you. Yeah, I can comment on that. We were successful with an insurance company. We have other insurance companies very interested, but it's still a slow and difficult process. But I think you identify, innovative partners that are open to implementing, value-based pilots. This is how it started with us. I had an insurance company that had interest in, we don't call it bundled payment. We created what was called a case rate, where we basically, and it's something that, I was very fortunate to have a very forward-thinking insurance company. We sat down and said, what would be an ideal treatment program? What would it look like? And then basically, what would be the estimated frequency of treatments? We looked at their patient population and we looked at the different diagnostic codes, and it was a lot of guesswork. And I guess we got a little lucky that we didn't. Obviously, there was a reassessment after a few years that suggested we should be significantly more reimbursed for what we are providing. That didn't go that far, but we still had a model that was viable. So we continue doing it, and now we adjust the negotiation with insurance companies. But the way that you do it, we took responsibility for taking care of patients. and it was a really value-based proposition. Fortunately, our software system is capturing all of the outcomes that we want to capture, and reports it automatically back to the insurance company for each individual patient on a monthly base. We can do it bigger reportings on a quarterly base. So it was easier for us to talk to an insurance company because they don't fund a pilot program, keep their fingers crossed for 5 years and hope to eventually have done the right thing. They on a monthly base can see what the performance is, which of course incentivizes me. We all preaching here the same gospel. These typically well reimbursed services are critical for these complex pain patients, but chronic complex patients in general. So since I could negotiate a case rate with the insurance company, I could then basically hire all of the specialists, and we to add to what we have naturopathic doctors that I could put under this bundle, yoga, tai chi. We even had Zumba instructors at one point. I could basically turn around and get practitioners into my model and pay them. I could negotiate payments. Typically, we did partial employments, but it works best if everybody is just on payroll and working as a team, and you just pay them fairly, and they don't have any of the economic background noise in their head. They can really focus on treating the patients. And as long as the outcomes are there and you calculate a good case rate or reimbursement model with the payer, everybody wins. We've treated more than 10,000 patients in a 1-year program, so we have substantial data. And I can tell you from having been there from day one, all of the services we're talking about right now are critically important for the success of our program.
So can I add just a little bit? So our process was the same as yours. Built it, the intensity, what services, we created a bundle. Then the insurer wanted to have a shadow fee-for-service utilization. How many acupuncture visits were there, et cetera. And it's not really, our bundle right now is not really value-based. We have no incentive for quality. We are looking at outcomes, but we have not kind of gained that. The concern I have is that the continued emphasis on monitoring utilization of services from the payer perspective is not productive, since we've already proven, as you have, that your outcomes are of benefit. And so in that black box of what we use to achieve those outcomes is not important to them. And so that continued worry about that. The second piece is the growth in just like it's fee-for-service, the growth in costs over time. Our bundle with Blue Cross has been static for like 3 or 4 years and has not increased with the cost of services and CPI. So we'll run into the same problem that Dave Elton just emphasized with PT and chiropractic. Lastly, interestingly, we're using Blue Cross is having this bundle with them, opened the door to having a bundle with Medicaid, because we have outcomes, and we were able to convince that. And a lot of it is about relationships and convincing, going individually from one person to another to convince them, and then send one person to another person. We sent Blue Cross to Medicaid to convince them to do this. And the second piece that it opens up is a mindset of innovation. So in primary care, Blue Cross is interested in supporting integrative therapies curated by us, connected to primary care, and paying it to primary care, who would then pay the integrative providers through using the psychiatric collaborative care model that Medicare has as a model for paying for integrative care connected to primary care. So we already have some models that work. We should use them innovatively, and having those relationships opens the door to having that discussion. Thanks.
Thank you both, Josh and Toby. And I see that we have another hand up as a panelist, but I think we're going to jump to an audience question and then come back to some of the panelist questions now. So Amy, I'm going to turn it over to you to take some of the Q&A the questions that are coming in, because I see we've got a lot of questions.
Yes, thanks. And we want to, we've got 15 minutes left just for everyone to understand. We want to make sure we get as many questions answered as possible. So let's see if we can fire off some quicker answers. A question for Chris. With TELUS Wellness, there's some people wondering if you're going to be adding other providers to your crew.
Yeah, so we've talked about other providers, and I could probably go through a list of them. We're kind of laser focused on the 5 we have, and the reason is you only have so much capacity to kind of build the network as well as kind of build the algorithms around the clinical science. And we found that these 5 resonate with the employers. I'd say that after our pilot in 2022, we now have 3 employers on our platform with about 2,000 members. We expect to have over 10,000 members in Q1 with the employers that we're going to be adding with kind of like active contract negotiations. So what I would say is that these 5 modalities kind of resonate the most with employers. I mean, we've talked about yoga. We've talked about, one exception would that be health coaching. And we believe the health coaches could serve more of a navigation role for some of these and trying to bring some of these together. But that's the exception that we kind of have working on right now.
Great, thank you. Amy, you want to
yeah, just another one, and then we can circle back. So Karen, and I know you had your hand raised before too, so this may weave into what you were planning to say, but there was a question in terms of where to spend advocacy energy. Do you suggest working on value-based payment or mandating insurance coverage for integrative approaches to treat pain?
Yeah, so yes and yes. I don't know that you can choose, honestly. I think you have to have the coverage and the payment alignment. And I think we've heard that throughout the discussions that we were having earlier. What I was just writing in the chat was what I was going to add, and I'll do this quickly, is that in answer to Isabel's question around, what's so hard about this? I think we see many bright spots around the country of where value-based payment and care are working well, much like described here in this presentation today. The biggest challenge is scalability, which is also really one of the goals of having this conversation today, is how do we scale these? And I think while we'd love to wave a national magic wand and make that happen, I think the realities, and again, I've heard this today, differences at the local level or state level around mandated benefits, around the level of interoperability, both within the traditional healthcare system and with integrative providers and other non-traditional providers, different workforce differences, market differences. How consolidated is the insurance market? Do you have a dominant payer that can drive things? Do you have a CMMI model that you can tag onto? So many variables at the state level. So I think conversations like this are so important to activate leaders in state change, which I'm seeing and hearing in the chat, including referencing the BRIE Collaborative in Washington State, where I had the opportunity to participate immediately before joining the Academy. So I think scalability is the key, but it's not going to happen nationally. It's going to happen locally.
Interesting. Great answer to that. Another question we've got is for Dr. Toby. How is the team trained to work collaboratively and understand each's approach?
It's a very important question. We actually have an internal training program. It's about a 1-month onboarding. And then we have a team that we call an alpha team. These are, basically our rock stars that have been working in the system for a long time, and they really understand the values and really understand, the way that you treat. Because one side note, you can't just go through the regular hiring process and look at the CVs, look at expertise, and then hope that these people that are trained to work by themselves are really good team players. And this is just something that we've learned the hard way. And I see nodding heads here. It's just a different approach to an integrated transdisciplinary treatment. But we are, we are getting really good in identifying people that really fit, and then they just have to be trained. And this alpha team that I mentioned just goes around the clinics and makes sure that we have an integrity and a consistency when it comes to deploying our modality. And lastly, again, we have a technology platform that is guiding. When I mentioned that we can align provider behavior, it is in a way our system suggests treatment, suggests questions, suggests the next steps depending on the data that was incorporated. So we do both. We do training, and ongoing training through this alpha team, but we also leverage technology to prompt people to do the right thing.
Great, thanks for that. Amy, a question from the audience, or do we want to do a panel? I know we had Dr. Church had a comment. Did you want to make a?
Yeah, I think Dr. Church had. Let's turn to Dr. Church and as you answer your question, Dr. Church, we did. Someone also asked, which was partially answered by Dr. Nagel, who I know is out there. Should every medical practice and facilities have EMR? So if you want to integrate those thoughts.
Gonna follow on to what was said earlier from Dr. Johnson about the advocacy portion, and I guess I would say be careful with when you say mandate, because it might not be what you want. So that the flexibility with some of the bundled things where it's the responsibility of the team to pick out what's best for the patients, I think is a nice model for that. And with regard to billing codes that will work as well, I think as the data rolls in, that's going to be a requirement to make a CPT code. But even then, the bundled model that's part of a value-based perspective is going to be a requirement. With regard to EHRs, it's a love-hate relationship for me. I think we all have some pain points with that, but certainly integrated care is very difficult if you can't share data well. And so almost all of the programs that involve comprehensive reimbursement from CMS require a EHR underlying. I don't think that's a requirement of this code set that they have, but it certainly has a role for that, for making things streamlined, and communication is paramount for that.
Great. Amy, another question from the audience?
Yes, we have many questions here.
I have one actually that people were asking.
Yeah, go ahead. Go ahead.
Which is the difference between transdisciplinary and interdisciplinary. We've got a few questions on that. Who wants to take that?
I can give it a quick shot. The way that I like to use an analogy is if you envision a different fruits. Let's say you have an apple, a banana, and a peach. All of these are different specialties, like a medical doctor, psychologist, and a physical, a PT. If you were to eat them separately, that's kind of the regular care that we have. If you slice them up and put them all into a fruit salad and you eat it together, that would be the interdisciplinary way of treatment, where you do it in parallel and the experience is different. You can imagine that if you take a bite from an apple or take a bite from a banana, it's separate experiences. Fruit salad, it already mixes. That was interdisciplinary. Now transdisciplinary, you put all of that into a blender and you make a smoothie. So you don't really have these different parts anymore, and it doesn't really matter who's doing the care. Let's say that you need vitamin C. As long as you have the right amount of vitamin C in that smoothie, it doesn't really matter if that's vitamin C came from the banana, the apple, or the peach. And this is the way that we look at transdisciplinary care. What is the treatment requirements of the patients, and then who is the best in the team to provide that? And sometimes there's different parties of the team doing different versions of it. So it's really dissolving the boundaries of disciplines. That's what transdisciplinary is.
And sometimes
I love the analogy.
Into two disciplines working together at the same time with one patient. I mean, that's the blender, right? So I agree. That's a good analogy. Thank you.
Great. And now, as we're just 5 minutes out, because this is so exciting, and thank you all for the questions. We will do our very best to get the rest of these questions answered. You will have the webinar, the recording, most likely a transcript as well, all available online here soon. So everything will be shared, because that's the point, is we're trying to make change. So on that note, we'd like to do a last round robin with our panelists so that you all can, so panelists, start thinking for a minute. This is where we want to just quickly nuance into action steps. So kind of thinking back to Isabel's question, and Isabel is a researcher in this space. She's someone who's going to be writing about these kinds of things. Yet, if she's confused, so are many others with less, who are less involved on the research side of this. And we want to think about action steps. So, what can a multi-stakeholder collaborative like ours, and working with so many other groups as well, what opportunities do you see for us to take action to advance value-based care in pain? So let's limit you all, please, to no more than a minute. And let's start with, does anyone want to start? Or I'll just call on you. Isabel, start, please.
So I just want to speak for the role of research in advancing this. I think some folks have highlighted, I think there's real value in health services research, in health economic research, and in implementation research for helping us to identify best practices, strategies, for getting these types of practices scaled. I just want to applaud the Alliance for bringing people together. And I think that bringing together these types of multi-stakeholder groups to inform the research agenda is going to be really important and something to keep moving forward.
Great, thanks. Karen?
I can go next.
Yeah.
Oh, go. Are you ready?
I'm ready. And I keep it
Toby? All right, we'll jump to Dr. Toby, please.
Yeah, I'll keep it short. I think, again, you have to continue doing what you're doing right now, because the three, I think that you have to create a win-win-win. And the three components are going to be the patients, the providers, and the payers. So you have to look at the healthcare system and say, okay, how do we create a system where the patients get better, the providers get reimbursed fairly, they have to make more, the same or better money than they're doing right now. And how can we do that by still saving money? Now, the good news is there's a lot of opportunities for improvement when you look at where the money goes right now. So I think it is not a dream. It is very realistic to create a model where you pay less, the providers can work in an environment they want to work in and get reimbursed well, and the patients get better. So that's why I'm on this webinar, and that's why I'm doing what I'm doing, just like pretty much everybody else on this panel.
Terrific, thanks.
So this is an easy button then, because Dr. Toby said pretty much what I was going to say, but I think when you're talking about multi-stakeholder change that is required for this, you have to always take the lens of the patient who benefits the most from this and really bring it home, because that's the one thing everyone sitting around the table cares about is the end result for the patient. So start there. There are a lot of private local actors that need to make changes that they don't necessarily see from any other perspective. And I think that's an important influencer, but you also need to be very specific in what do they need to change and how, and point them to the resources that help them do that, whether that's federal or state policy or other local community-based resources.
Thank you. Fantastic. Dave?
It's you get what you pay for. And to the point of the new codes, it was very quick math. And Amy, as you know, I sent you immediately. I said, well, they're paid less for these. Nobody's going to use them. You get what you pay for. And so in all of these activities, we have to understand the math equation on the economics and how does the money flow. And, well-intended, great efforts where the economic math equation doesn't work, it's not going to scale. It's not going to grow. And you just right out of the blocks immediately have to get grounded in the economics. Clinicians don't like to hear it. We don't want to, but that's just gravity. I mean, anyway.
Absolutely. Yes. Chris?
Yeah, I mean, I think like one of the challenges I see, and this is an outsider looking in who hasn't been part of kind of this group at all, but I think, there's a little bit of everybody's got a different approach. So it seems to me that there has to be almost some sort of core approach that everybody agrees on at some point. And I don't know what that core approach is or even how you would get to that core approach. And then there might be some supplemental components, but if it feels a bit to me like over time, everybody's got like an approach, and that's part of where the research comes in. People are learning all the time. But if there's some sort of agreement on core messaging and core approach, I think it could actually expand the ability to kind of move quicker. That's just kind of like maybe an outsider's view looking in versus somebody, that's been engaged, pushing this rock up the hill for a long time.
Great point. Josh?
Blind spots and positive outliers. So this kind of collaborative identifies the blind spots, and there are different skill sets spread throughout the room here. And I don't have a lot of technological know-how. Dr. Toby does. So for example, so I think these types of collaborative discussions on an ongoing basis would lead us, Chris, to develop a unified approach that would be the best in class. And the research is very important, which I'm the director of research, so I'm going to be doing a lot of that.
I love that. I love that. Have we got everyone?
I would just add, in any other market, consumers would drive all this. And unfortunately, the voice of consumers and patients, it's difficult for them to make a difference. So it is going to be up to us. And this research that y'all are doing and these great plans and models, it's fantastic. And I hope that some stakeholders are listening closely. And because as you publish these data, the insurance providers and employers, they're going to demand that we do this different. And we'll have another way to make this happen when that data is abundantly clear. And so I'm excited about what's next. And even with the limitations of the new CMS codes, at minimum, it prompted this meeting today. So there has already been a lot of great things happening from that. And so I'm excited about what's next and everyone working together on this.
Fantastic. And as we are now rounding our corner, I want to thank Cindy again for moderating this week with me. I have known Cindy for so many years, back with the Massachusetts Pain Initiative a million years ago, and just love working with you. And before I kind of close this out, Cindy, did you want to also share an answer or any other comment?
Well, I had actually a last question for Dave, and that is, why do the insurers rarely pay for failed surgeries over and over again, and it's got to be a huge cost, and they don't pay for something as simple as acupuncture?
An answer, but not on a recorded call, but I'd be happy to.
Yeah. Well, like I said, we will get more information. I feel very excited that this has really gotten people wanting to talk about this more and work together more. I think I am among my people on the panel and also in the audience who understand that it's really these multi-stakeholder groups that are the only way to move us forward. None of us can do this by ourselves. And so we just want to thank all of you for the time you spent today sharing your information. For those who have listened in, I know we had many more register, so I know this will be going around and being watched many times after today. And the resource listed at the very bottom of this slide is the link, which you'll find on our website, that will have all of this information, plus the recording slides, transcripts, and more in the next week or so. So thank you all so much. Have a fantastic rest of your day and rest of your year. And we will look forward to talking with all of you soon.
Thanks, everybody. Thanks to the panelists.
Thank you.
Bye, all.